Okay, so yes, we are live, and let's just see how many are there, and then we can start. I'll just share this link. Okay, so okay, so I think we can start, right?
Sure.
Your mic is off.
Yeah, I am talking from another connection actually because there is an issue in this computer. So
Okay,
I'll be
okay.
talking from the phone connection and presenting from the
Cool,
desktop.
cool,
Is
cool,
it
cool.
okay? Yeah, okay.
Yeah, definitely. It's fine. It's fine. That's all. That's fine. Everything is fine.
Thanks.
Yeah,
Yeah.
it's perfect. Okay, so guys, let's start. And today is our fifth module of the Master Certificate course in Diabetic Pharmacology. And today we have with us Dr. Shivani Desai. She'll be taking the topic of type 1 diabetes. So she is right now working at Dr. D.Y. Patil Institute of Pharmaceutical Sciences and Research, Pimpri, Pune. Dr. Shivani Desai, let me introduce her. So Dr. Shivani Desai is a clinical pharmacist with wide experience in clinical research and academic experience. After completing her master's in clinical pharmacy, she did her PhD in pharmaceutical sciences, and she is currently working as assistant professor at Dr. D.Y. Patil Institute of Pharmaceutical Sciences and Research. Along with academic profile, she is also involved in various preclinical and clinical projects at her institute and also in collaboration with other firms. Before joining DPU Pharmacy, Dr. Desai has worked as a medical writer at DocPlexis and research associate at KEM Hospital and Research Center and head of research at 7 Orange Hospitals. Currently, she is working on various preclinical and clinical projects such as development of vaccine for type 1 diabetes mellitus, preclinical modeling of development for type 1 diabetes, clinical trial for stem cells in diabetic complications, clinical evaluation of possible causes and complications of type 1 diabetes mellitus, preclinical study on applications of stem cells in diabetes and in diabetic wound, preclinical studies on application of stem cells in pancreatic transplantation in type 1 diabetes mellitus. She is contributing to the field of science by presenting at various conferences and publishing high impact papers in national and international journals indexed in Scopus and Web of Science. So over to you, Dr. Shivani. Thank you very much for joining, and thank you very much for accepting our request.
Thank you so much, Dr. Singh, for a wonderful introduction. So I am not able to share my screen. Can you please allow me?
Yes, please go ahead. Yes, you are allowed. No?
Not yet.
One sec.
Yeah.
Okay. What it is showing?
Can you allow the
Okay, yeah, please go ahead. Now,
the
I
other
think,
one?
yes.
Yes, yeah, I can do that now.
No, now you can. Now you can. You can please go
Yes,
ahead.
yeah. Just a minute. Is it visible now?
Yes, it is coming.
Yeah. Okay. Just a minute.
Okay.
It is not moving.
Yeah, this is even not visible this side.
Yeah, just okay. This one. Sorry for this.
Oh, no, it is. Take your time.
Yeah, it is available
Yes, it is
now, I
now
think. Yeah.
moving.
Okay. So we'll be starting with the basics of type 1 diabetes, and today's session will be an overall overview about what is type 1 diabetes. And we'll be also taking one small case, which is pertaining to type 1, which will be a simple but important case because those are the symptoms which we usually see in the patients who are admitted with newly diagnosed type 1. So before going to the topic, I would like to tell you that whenever we are talking about diabetes mellitus, so basically there are two types of diabetes, mellitus and insipidus. Now specifically we are talking about endocrinology. So there it is diabetes mellitus. Now when we say a word diabetes, we always think about type 2 diabetes. So this type 1 diabetes is quite ignored area. And because not many people, as compared to type 2, not so many people are affected. But if we take it individually or independently, type 1 is also having a lot of epidemiological data, which shows that a lot of people are, especially children and adolescents, they are suffering from type 1 and they are diagnosed. And then throughout their life, they have to deal with this type 1 diabetes as well as their complications. Now, why I feel personally, at a personal level, I feel type 1 diabetes is much, you can say, deteriorating kind of a disease as compared to type 2, because this is specifically the onset happens in childhood. So, a child, sometimes it happens that the onset is happening in the children who are just 3-4 years old or 5 years old. They are just not able to comprehend what is happening. Then in some of the cases, the onset happens during their when they hit the puberty, like 12, 13, 14 years old. So that is also a very delicate time. And because of the other hormonal changes, already the child is in some other state of mind, and then this type 1 is just hitting them. So that is also one of the concern, that this area should be really talked about, and more and more people should be aware about it. So I'm really thankful to Dr. Ajit Singh, CliMed, and the associated people with him to take up this as one of their topics of concern in this whole session, a whole course. So we'll be, as I said, we'll be going through the overview of this disease, which will involve the general epidemiology, etiology of the disease, risk factors, sign and symptoms, pathophysiology, which is really important to understand, because if we want to continue our research in type 1, then, or in case of any disease, we have to understand the pathophysiology first. So if we know the problem, then we can have some solutions. Then diagnosis, because diagnosis is also a very important part of type 1 or any of the diseases, because if we are wrongly diagnosing the situation, then the treatment will vary. So diagnosis of type 1, stages, complications, management, guidelines, and current research which is happening. Then at the end, we'll be taking a small case which will show some of the highlights of this whole presentation. So to start with, type 1 is an autoimmune condition. So again, I'll be continuously comparing type 1 and 2 because this comparison is really important. You should know the difference between these two types of diabetes. type 1 and type 2, right? Other kinds of diabetes are also there, like gestational is there, Modi is there, but then some other time, I think Dr. Singh will be having some sessions on the other types of diabetes as well. But here, 1 and 2 will be continuously talking with a special emphasis on 1. So to start with, type 1 diabetes is an autoimmune condition. So autoimmune means usually our immune system is really important. It is the shield of our body, and it protects us from all the kinds of infections or any encounter with any kind of foreign body. So this works really well, but it is like a it is a double-sided sword. So when this immune system is getting disturbed, and our immune cells are not able to understand the difference between self molecules or self antigens and non-self antigens, in that case autoimmunity is taking place, or autoimmune disorders will happen. So this is a condition, type 1 diabetes is a condition wherein the body is not able to, the immune system is not able to recognize the self molecules, okay, self proteins to be specific. So it is not able to understand that these proteins are our own cells, are our own property, and they just think that it is something not normal. So the immune cells will attack those, will start their hyperactivity, and that is called autoimmune condition. Now, because autoimmune condition is not like a one time episode or 2-time episode. In general, autoimmune disease I'm talking, right? So because immune system is always going to think, it is fed in their brains, in our immune cells, the proteins are not our own. So our own body's proteins are being attacked. So in diabetes specifically, type 1 diabetes specifically, our immune cells are attacking our pancreatic cells. Okay, so the immune cells are also our own, pancreatic cells are also our own, but then there will be a misrecognition, and because of the misrecognition, our T cells, especially cytotoxic T cells, we'll see the different T cells as well, but especially cytotoxic T cells are also are specifically involved in this whole war kind of a thing which is going on inside the body. So cytotoxic T cells will be activated, and because of the activation of cytotoxic T cells, they will be targeting our own body's pancreatic beta cells. Okay, so they have the special affinity towards the special hatred towards the pancreatic beta cells, and they will be destroying the pancreatic beta cells. Now, because the pancreatic beta cells are destroyed, therefore, the cells are not able to produce the insulin and secrete the insulin. Fine. So because this insulin is not secreted, therefore, then the following cascade will be that our glucose, because insulin is very much important for our body to uptake the glucose, whatever food we eat, and then that food will be broken down, and then the end product is basically the glucose. That is the energy source of our body, right? So those glucose molecules will be taken up by different cells of the body, and for energy and for whatever purposes it follows. Now insulin is not there, therefore the body we are eating good amount of nutritious food, but the glucose is not getting uptake. Pura metabolism ho raha hai, all the metabolic processes are in place, but whatever glucose is produced in the body, that glucose is not getting uptaken by the different cells and different tissues of the body. So availability is there, but we are not able to use it. The patient basically is not able to use it. So here the muscle gain will be an issue. Muscle gain will not be there. Muscle deterioration will be happening. Okay. Now body is not having proper amount of energy. So whatever energy we are getting is all from the glucose, but glucose uptake is not happening. Still, it is there in the bloodstream. Still, it is not happening, right? We are not able to use it. So what the body will do for energy purpose, they will start breaking up the fat molecules and muscles of the body. Okay. So because of the breaking up of fats and the muscles of the body, there will be a condition known as ketoacidosis, because the end product of this metabolizing of the fats and muscles of the body will produce ketone bodies, and that will cause ketoacidosis. That the term is known as diabetic ketoacidosis. Okay. So when this diabetic ketoacidosis happens, that is the trigger when the body will start showing the symptoms. Okay. So that is the time when we understand that the child or adolescent person is having some issue when they will be admitted to the hospital. That time, because of the high level of ketoacidosis, the doctor will be able to diagnose that the person is already suffering from type 1. Fine. So here again, we are not able to understand the pre-diabetic condition in type 1 diabetes. Okay. In type 2 diabetes, basically what happens that we are all aware that it is a kind of genetically carried forward disease. So if my parents are suffering from diabetes type 2, then at the age of 30, 40 years, I'll be mentally prepared that, yeah, I may have type 2. And then continuously within 6 months or every year, we do our checkup and all. So it is like we may detect the pre-diabetic state. Whereas in the case of type 1 diabetes, no parent will be thinking that their child will have some issue during their childhood, right? So it is like very uncommon that the children are going through their yearly or 6-monthly checkup. Usually we don't do it for the children. So we are not able to detect the pre-diabetic state in type 1. So when the child is brought to the hospital, that time already the child is having severe diabetic state. Fine. So this is the why I explained this is because this is the seriousness of this topic. Right. So now, as I said, type 1 diabetes is an autoimmune condition, and this will need the lifetime insulin dependency. Okay, because in this condition, body's pancreatic beta cells are completely destroyed, or majority of the cells are destroyed. Therefore, the body is never able to produce insulin, and therefore we need external insulin for our body. So this is a lifetime situation currently. Fine. Now, this type 1 diabetes is not preventable or curable right now. We can just manage type 1. Okay, there is no prevention which we have currently, and we unfortunately we also don't have any cure for type 1 diabetes. This is the figure which I have put from one of my studies, just to show you the histopathology. These are not human cells; these are the real mice pancreatic tissues. But the similar condition is happening in the humans also. See, here we can see in the first one, normal pancreatic tissues are shown here, and there are no infiltrations, right? All the tissues, all the cells are intact. Whereas in the second figure, pancreatic tissue is damaged. We can see the infiltration, we can see the damage of the pancreatic cells. So this is the condition. This is the onset of the disease in type 1. And once the disease starts progressing, these gaps will be increasing. And the deterioration, the destruction of the tissues is very evidently present. Now, this is the data which is given, which I have taken from the International Diabetes Federation, and that is from 2019 data. And here, globally, more than 1 million globally, more than 1 million children and adolescents are suffering from type 1. And in India only, there are more than 95,000 children and adolescents. This is the data from 2019. The data is still increasing, and this is taken from IDF and not WHO. Now, coming to the etiological factors and risk factors. So there are various, I thank Dr. Singh for this slide, because he has provided me with this particular data about the etiology and the risk factors. So basically, there are various reasons which we are anticipating that, these may be the reason, this may be the reason, but unfortunately, the perfect reason or the exact reason is still unknown. But still, there are some studies, even we have conducted, we are in the process of conducting the studies. We have got some data, but we are not showing it here because my study is still not published on this. So there are various papers which are available, which shows a strong correlation between the viral load and the development of type 1. Okay. So here, even this data from WHO website, it shows that CVB virus, that is a very commonly occurring virus, which can cause onset of type 1. So basically, these viruses, one is CVB virus, then cytomegalovirus, then mumps, rubella, rotavirus, all these viruses, even coronavirus. Okay, so that another study is still going on, that after this corona impact, just a I'm so sorry. So in this, after this pandemic, there are a lot of cases where we are able to see the onset of abrupt onset of type 1 diabetes. Okay, so how this viral load may be increasing the onset, or maybe putting the people on the risk of type 1 diabetes is, virus is an external organism, right? Still it is like dead alive, it is still a mystery, but still it is an external thing which is coming into the body. Now, our body, in this autoimmune mechanisms, the body's immune system is already compromised. Fine. That means those people who are at the onset of who are the patients of type 1, they are having some genetical or some, what do you say, mutations, we cannot say, some disarrangement of the genes, of the genetic codes in their body. And that is the reason they are developing autoimmunity. So in this case, if there is any attack by the virus, those viruses are also manipulating or changing the genetic codes in the people. Okay. And that genetic codes, if they are changed as per the requirement of onset of any autoimmune disease, specifically type 1 disease, then they will be suffering from the clinical onset of the disease. Right? So basically, the hypothesis is there is no paper which is short saying that this is the mechanism, but there are various hypotheses which are there. So viruses are basically trying to manipulate the codes, genetic codes in the people, the patient's body, and because of the manipulation of those codes, it is causing autoimmunity. Right? Now, next is cow's milk protein. So this is also one area which is like, some of the papers are showing that cow's milk protein is causing type 1. Whereas some papers are saying that, some studies are, or some scientists are saying that cow's milk protein has nothing to do with the onset of type 1. But logically, even I believe that cow's milk protein has a major role to play in the onset of type 1 diabetes, because cow's milk protein, we all know that the protein present in cow's milk is bovine protein, right? And that protein is somehow acting as an antigen, and somehow it is creating the manipulations in the, here we cannot use the word mutation. Okay, it is not a mutation. It is showing some manipulation, causing some manipulations in the genetic code, and that this cow's milk protein ki wajah se this onset of the autoimmune conditions can happen. Now, another reason is insufficient breastfeeding. Okay, there are certain studies which are showing that the children who are deprived of breastfeeding during their fetal development, that time, if the mother's milk is not provided to the child, to the fetus, to the newborn, then they are after 7 years of age, they are bound to develop. They are at a higher risk to develop type 1 diabetes, because mother's breast milk, we all know that the breast milk from the mother is very nutritious, and it is having all the good proteins in them. Okay, which will be enhancing the immune system of the baby. So if we are depriving the baby from the mother's milk, their immune system will not be as strong as compared to the children who are getting mother's milk. So here again, the immune system is not growing very nicely in the body, in the baby's body. So they are more prone towards developing autoimmune diseases. They are also more prone towards the children who are deprived of mother's milk. They are also more prone towards developing of immunodeficiency diseases. Okay, but autoimmune diseases are also happening. Then this is all about the same. Okay. Now, next, coming towards the sign and symptoms of type 1 diabetes. So they are very much similar to type 2 diabetes, like increased thirst, okay, increased frequency of urination, then extreme hunger, okay, unintended weight loss. These are all fatigue and weakness, blurred vision. These are all the symptoms which they share with type 2 diabetes. The type 2 people also have similar kind of diseases, symptoms. Now, one more prominent characteristic, or one more prominent symptom is bedwetting in children who previously didn't wet the bed during the night. So this bedwetting of the children, which is happening in the children, is one symptom, because the children who are affected with type 1, they have this tendency to urinate frequently, right? So when they are sleeping, they are bound to do this bedwetting issue. Then next is complications associated with type 1. These are also very much common with type 2. So we are not getting into too much of detail here. So diabetic ketoacidosis, I just told you before that why diabetic ketoacidosis happens. So just to repeat for the people if they have joined a little late. So in that case, diabetic ketoacidosis happens because whatever food we are eating, from that glucose is getting generated. But that glucose is not able to take, but that glucose is not taken up by our body's tissues, okay, for energy. So our body, even though the glucose is present in the bloodstream, still our body, the cells of our body are not getting that glucose because the transporter, that is the glucose, that is insulin, is not present or present in very less quantity. So that is the reason body cells are not able to get the energy. Now, in this condition, when the cells are not able to get the energy, our body is trying to break down fats and muscles, okay, to get the energy out of that. So because of the breaking down of the fats and muscle tissues, the byproduct of this whole particular cycle is generation of ketone bodies, and that is causing ketoacidosis, right? Then another complication associated, major complication associated is retinopathy, then neuropathy. And because of neuropathy, foot problems, foot ulcers starts happening, because in neuropathy, the conduction of the impulses is not happening properly. So in that case, what happens, if there is any little bit of injuries also there, it is not going to the brain, because the conduction system is getting delayed because of the neuropathy. The neurons are not able to function properly. So wherever especially in the foot, if there is any kind of injury happening, the healing will not happen. Okay. And then it can develop into foot ulcers. Foot ulcers can also lead to very serious conditions wherein the leg amputation needs to be done. So diabetic foot ulcers are also very, serious issues happening. Then next is kidney disease, that is nephropathy, because nephropathy usually happens in diabetic conditions because the load on the kidney is increasing basically. Okay. So whatever food we eat, whatever glucose is produced from that food, from the metabolism of that food, glucose is not taken up in the tissue. So where is that glucose going to stay? It is going to stay in the bloodstream, right? Now, because the glucose is there in the bloodstream, and then the filtration, we all know the urine formation process, right? So the filtration will be happening by the kidneys. So there will be an overload of glucose in the nephrons of the kidney, and that will lead to nephropathy. Various heart and artery diseases, various cardiac disorders are also happening in the people who are diabetic, type 1, type 2 both. And the major complications, so all these above complications, diabetic ketoacidosis, retinopathy, neuropathy, foot ulcers, nephropathy, and cardiac diseases, these all are the symptoms which are seen in type 1 and type 2, both the kinds of diabetes. Hypoglycemia is one thing which is happening more in type 1 patients as compared to type 2 patients. Even our case, which is following, that is also having the mention of this hypoglycemic condition which is happening in the patient. So now, why hypoglycemia happens more in type 1 patients? We know that in type 1 diabetes, there is little or no insulin production, and therefore we are taking insulin from outside. Okay. Now, sometimes it happens that, in fact, many times it happens that the children, because children are not very particular as compared to adults, right, about their medicines or about their food patterns and anything. So there may be conditions when the child is not taking proper food, the child is not eating proper food, but insulin that insulin the patient is taking. So insulin is there, but proper food is not there. So what will happen? Insulin is going to deplete the sugar level more than normal. Instead of bringing the sugar level to normal range, because of the high insulin and low food content, the insulin is creating the depletion of the glucose below the normal range, and that is causing hypoglycemia. Now, hypoglycemia further can lead to various other complications. Okay, so in this case, just a minute. Yeah. So in this hypoglycemic state, the person is also bound to get into coma. Okay, so hypoglycemic shocks, hypoglycemic coma are very dangerous, and if it happens in the child who is not able to even comprehend what is happening to the body, then it is worse, right? So hypoglycemia is one condition which we need to take care, and we need to measure the glucose level before taking the insulin. So the children who have type 1, before every meal, they measure their glucose level. And based upon the value which they got from the measuring of the glucose level, based on that value, they are taking the insulin units. Okay. So just imagine how difficult it is for the child to do all this. Before every meal, before breakfast, before lunch, before dinner, they always have to first prick to get to check their glucose, and based on that glucose level, based on that, then they have to take the insulin. Of course, the pumps are available, the monitoring systems are available, but still they are very expensive. Okay, glucose monitoring systems or glucose monitoring devices are there, which is just there as a patch. The child wear it as a patch, but even the pumps are there, insulin pumps are there, so they just have to press that particular button, but still they are very costly. So not everybody can afford those machines or those devices. So it becomes really tough for the child to every time prick the finger and see their glucose and do their insulin dose adjustment and everything. So that was about the overview about type 1 diabetes. Okay, that we have just learned about what is autoimmune, how autoimmunity happens. Then we came to the sign and symptoms. Then we came to the complications, and then we just studied the etiology as well. Now coming to the pathophysiology. So pathophysiology is really important because as I said, if we don't know the mechanism, how disease is happening, then to manage it is a problem, right? So first we need to, before going to the management part, first I need to tell you the pathophysiology. We need to discuss this first. Now here, the first, again, thanks to Dr. Singh for this particular slide. I have just made some modifications, but apart from that, thanks for this. So to start with, there should be some trigger factor for any disease, right? So here the trigger factors are genetic predispositions and environmental factors. But apart from these two factors, again, we don't know. So the genetic connection of type 1 is not as strong as in type 2, because when the patients come to the clinic or to the diabetic clinic or to the hospitals, when we take their history, we are able to see that none of the parents' sides, neither maternal side, neither paternal side, they are not having any kind of type 1 diabetic history, or they are also not having any kind of autoimmune diseases history. Okay, so rarely it happens that somebody from the family is having some autoimmune disorder or type 1 diabetes or any other like rheumatoid arthritis or any other SLE, any other kind of autoimmune disease. But most of the cases, family history is not there. They don't have positive family history. Okay, but still some genetic predispositions are associated, and the major factors involved are environmental factors. Okay, because environmental factors, if you would see the data of any kind of autoimmune disease before 20 years, so the incidence as well as the epidemiology, if we see the number of cases, they will be lesser as compared to the present scenario. Okay, because a lot of environmental factors have changed over these. Every decade, the number is increasing. With every census coming out, the number of these autoimmune diseases are increasing, because immunity is not that strong nowadays, okay, as compared to 10, 20, 20 30 years before scenario. So there are a lot of environmental changes happening, and because of the environmental changes, our genes are changing. Okay, and because of that, the change in the codes of the genes, our immune system is getting modified, and they are exaggerating all the responses, all the immune responses, amongst which autoimmunity is one major thing. Okay, so due to certain factors, here the autoantigens form on insulin producing beta cells and circulate in the bloodstream and lymphatics. Means whatever genetic codes are changing because of whatever reasons, may it be genetic predisposition, may it be environmental factors. One more factor is there, which I've forgotten to mention in this slide, the lifestyle of the parents. Okay, so during the peri-conception time. Okay, so when the parents are planning a child, that is called the peri-conception. Okay, so when the parents are planning the child, during that time, what kind of environmental exposure or what kind of lifestyle exposure the parents are having, that also plays an important role. Okay, so what will happen? Whatever genes they will be passing on to the fetus, those genes will be manipulated, and those genes are exaggerating the immune responses, and because of that the child will be born with autoimmune disorder. Okay, so when the child is born, we are not able to understand this disorder because again there is a problem in the screening. What I personally feel is when the child is born, the government should be able to give this, because as we know that not everybody can afford all the tests, right? So maybe we can come up with a forum wherein we can place some of the requests to the government and health authorities also, that we should make some of the screenings, especially the diseases which are very common in the children, we should be able to make the screening. So if we screen the people, if we screen the newborn children at the very initial level, I think that in that case we can prevent, or we may be able to prevent the onset of such diseases. Okay, currently we are not able to prevent because we don't know that the child is having this genetic composition in the body, right? So if we are able to come up with some kind of tests which we can make available to the newborn children of all the financial cadres, may it be rich, middle class or poor people, so in that case we will be able to comprehend whether the child is having any kind of autoimmunity or any kind of other immunocompromised diseases, and then we can start the preventive measures from that point itself. Okay, fine. So because of the genetic problems or environmental problems or the lifestyle of the parents, the genetic coding of the child is getting affected. Now because of the change in the genetic coding, the child's immune system is not able to comprehend the self and non-self proteins. So they are comprehending that our own peptides, our own proteins are some foreign molecules. So, and they will treat those particular proteins as autoantigens. Okay, basically antigen is which is coming from outside. Now, autoantigen means the peptide is our own, the protein is our own thing, but still it is getting affected. Still it is triggering the immunological responses. So we are giving the name autoantigens. Okay. So autoantigens are formed, and then these autoantigens are just circulating in the body. It is going everywhere. Now, because of the autoantigens, the circulation of autoantigens in the body, our antigen presenting cells, okay, they are the antigen presenting cells are the T cells. So basically there are two types of immune cells. We will not go into very much detail of these types of immune cells because it is again 2 hours session to go into the details. But in short, I'll just tell you there are two basic kinds of immune cells, T cells and B cells. Okay, so in this T cells, there are different categories again. So there are helper T cells, there are cytotoxic T cells, okay, there are regulatory T cells. So regulatory T cells are basically regulating the immune responses. Jitna chahiye utna response dega. Whatever, however response we need, the body needs, that response will be given. And this is managed by regulatory T cells. Another is helper T cells. Helper T cells are again Th1 and Th2. So they are pro-inflammatory. Th1 helper T cells are pro-inflammatory. They are the cells which are causing inflammation. Another type of T cells, T helper cells, that is Th2 helper cells, they are known as anti-inflammatory. So those cells are reducing the inflammation. So this balance is very important. Okay. And the third type of T cell is cytotoxic T cells. So cytotoxic T cells are the cells which are killing our body's cell. Okay. In case of normal infection, if there is any viral infection or bacterial infection, that infection, suppose if it is affecting some certain cells of our body, so cytotoxic T cells will kill those cells through natural process of apoptosis. Okay. But in the case of autoimmunity, our normal cells are also getting killed by the cytotoxic T cells. Fine. So this is the basic mechanism. Now, because of the activation of this T cells, they will then activate macrophages. Macrophages will then release interleukins and TNF alpha, and of course, they are also activating the cytotoxic T cells. Okay, and this TH helper 2 cells are releasing interleukin 4, which is now this interleukin 4 is responsible for activation of B lymphocytes. So T lymphocytes, I said there are 3 types of T lymphocytes. Okay, helper T cells, which are again type 1, TH1, TH2. Second is cytotoxic, and third is regulatory T cells. Another type of cells are B cells, B lymphocytes. So these B lymphocytes are the cells which are causing the production of antibodies. Okay. So now when there is any infection, in normal scenario, when there is any infection, the antigen is coming, getting exposed to the body. So T cells will be activated. They will again activate it. They will then activate the B lymphocytes, and then the B lymphocytes will produce antibodies. Those antibodies will kill the antigen. This is the normal mechanism, which we learn from 6th or 7th standard in the school, right? Now, in this autoimmunity, what happens? Autoantigens are there. That is triggering T cell response. And T cell response is again triggering interleukin 4. So these interleukins are all cytokines, okay? Now, interleukin 4 is then triggering B cell functions, B cell responses. B cells are getting activated, means the antibodies are getting produced. Now, what will happen? There will be a war going on because already we have some autoantigens in the body. Okay, in majority cases of type 1 cases, GAD is the autoantigen. There are other autoantigens as well, which we will see later. So, autoantigens are present in the body. Fine. Now B cells are there. B cells are again now producing antibodies. So those antibodies will be killing our own antigens, self-antigens. So again, that will cause antigen-antibody reaction will always cause inflammation. Okay. So because of the activation of B lymphocytes here, activation of the B cells, they will cause production of the antibodies. These antibodies will react with the self-antigens. Okay. This antigen-antibody reaction will cause inflammation, and because of those inflammation, cytotoxic T cells are damaging our pancreatic cells. Right? So this is the bottom line: destruction of beta cells with decreased insulin secretion. So if beta cells are decreased, automatically the insulin secretion will also decrease. Fine. So this is the pathophysiology. Now this slide, actually, we have already covered this thing. Okay, now what happens is, see here, because of the destruction of the beta cells, insulin secretion is decreased. Okay, so now before from some 10-15 minutes, I just told you that that insulin is a carrier, it is a helper, or it is a vehicle for the glucose to enter into our body's cells, right? So now this is the normal scenario. This is the type 1 scenario. First, we'll see the normal scenario. Here, glucose enters the bloodstream. So whatever food the person is eating, the patient is eating, the glucose will be produced after a lot of metabolic processes through the digestive system and liver. So glucose is there, and this is the blood vessel. Okay, and this is the another tissue, like the tissues wherein the glucose should be uptaken for energy. So there is this glucose is present in the blood. Okay, from whatever food we are eating, after getting metabolized, glucose is formed. This glucose is there in the bloodstream. And insulin, soon as the glucose enters into the bloodstream, it triggers our pancreatic beta cells. So you must be knowing the positive feedback mechanisms and negative feedback mechanisms, if I'm not wrong, right? So positive feedback mechanism means if we are, so if the glucose is coming into the body, that will trigger the beta cells, okay? That will trigger basically the hypothalamus of the brain. Hypothalamus will then trigger the concerned area in the brain, which is going to give the signal to beta cells to secrete insulin. This is called positive feedback mechanism. If there is no food in the body, insulin will not get secreted, okay? And if when we eat, when the sugar level, when the glucose level increases in the body, through this hypothalamic triggers, the signals are passed on to the beta cells to release insulin. Fine. As soon as the bloodstream is experiencing the presence of glucose, it will give the trigger to the hypothalamus. That hypothalamus will give the signals to through direct indirect processes. It will give the signals to beta cells to release insulin. So insulin will also enter the bloodstream. Okay. Then this insulin will be coming out, and this glucose will also be coming out through the bloodstreams through various active passive mechanisms. We'll not go in detail about it. And it will be there near the tissue in the intracellular space. Okay. Now this insulin will be binding to the GLUT receptors which are present. This insulin will be activating the GLUT receptors which are present on the cells of the tissue. Okay. Insulin will come. Insulin will first give the signal to the GLUT receptors to open up or to get activated basically. Okay. Once the GLUT receptors are activated, this glucose will be taken up by the cells. Clear? This is the basic mechanism which happens in you and me who are non-diabetic, non-type 1 diabetic or non-diabetic. Okay. Now the next scenario is type 1 diabetic people, okay, or patients. Same thing, through the blood, through the food, glucose is coming, okay, in the bloodstream. But the only difference is this bloodstream, whenever the glucose is coming, it is giving signal to the hypothalamus. Hypothalamus will give signals to the pancreas, but pancreas do not have beta cells. Okay, because of the autoimmunity, the beta cells are destroyed. Fine. So even though hypothalamus will send the signal, but still pancreatic beta cells will not be able to release insulin because pancreatic beta cells are damaged. They are dead. Okay. So there is absence of insulin here. So what will happen? In this case also glucose was coming out, okay, by active diffusion process. Here also the glucose is coming out in the active diffusion process, but there is no insulin available. Okay. So if insulin is not available, the GLUT receptors on the cells will not be able to get activated. And because the GLUT receptors are not activated, therefore, however amount or concentration of glucose is there, this glucose will not be able to get inside the cells because the doors are closed. Okay. And the door is able to open. The lock of this door is able to open only with insulin. Insulin is able to activate the GLUT receptors. But we don't have insulin here in this case. So GLUT receptors are not activated and glucose uptake will not happen. Fine. So again, this glucose will again go. So the glucose has no place to go now. So again, the glucose will be going to the back to the bloodstream, and the blood level will show high sugar content. Right. So this is the basic mechanism through which type 1 is affecting and how the blood glucose is increased, how the cells are deprived of glucose. This is the basic mechanism. In short, I have explained. Now there are some, okay, before going to the diagnosis, I would like to clear some type 1 and type 2 differences. Okay. So these are the basic differences. Again, they are not into very much detail because if we want to go in detail, type 1 is basically immunologically driven disease and type 2 is endocrinologically driven disease. Okay. So this is the basic difference. Now here, type 1 happens usually the onset in 99% cases, the onset is less than 30 years of age. Especially most of the cases are diagnosed before puberty. Some cases are diagnosed during puberty, like below 20 years, when the puberty hits till 20 years of age. Okay. And still there are some cases which can happen after in 20s also, but below 30 years of age. Whereas type 2, majority of the cases happens after 30 years of age because that is endocrinological disorder. Type 2 happens because of insulin resistance. Okay. Here the pancreatic cells are releasing insulin in type 2, but insulin resistance is created. We will not go in detail about type 2 right now. Next, onset is abrupt. Okay, type 1 the model is abruptly the person will start showing the activity, start showing the symptoms. Okay. Whereas in type 2, onset is gradual. The person stays in pre-diabetic state for a long time. Okay? And then the clinical onset happens gradually. Whereas here, type 1, clinical onset happens abruptly. Body habitus is lean, means the people who are type 1 diabetics are lean in nature, in their physique. Whereas type 2, during the onset, they lose weight, the weight loss is there, but then afterwards there is obesity, okay, or history of obesity. Insulin resistance is not there in type 1 because insulin is not there. Okay. If insulin is not there, how come there is no question of getting resistance? Whereas in type 2, insulin is produced, but there is insulin resistance. Okay. Then autoantibodies, they are most of the cases, 99% of cases, autoantibodies are present because autoantigens are there in the patient's body suffering from type 1. So obviously B cells will be activated. I just explained you the mechanism in the previous slides, right? So because of the autoantigens, B cells will be activated. Those B cells are producing autoantibodies. Whereas in type 2, autoantibodies are rarely present. Type 1 is symptomatic from the day 1 because diabetic ketoacidosis is the trigger point, right? Whereas in type 2, initially they are asymptomatic. Then slowly the symptoms will start happening. This thirsty and urination and all those things. Need of insulin therapy is immediate in type 1 because there is no insulin. Therefore, the insulin injections needs to be started from the day 1 of diagnosis. Whereas in type 2, insulin is needed, but that is like after long years. Like initially metformin or any other oral hypoglycemic agents, the medicines, the tablets are given, and type 2 is managed by medicines. Okay, but in later stages, when the person is not responding to medicine, at that time, insulin may be needed. Now coming to the diagnosis of type 1 diabetes, here there are various tests which are performed. Okay, so here glycosylated hemoglobin from the day 1. Glycosylated hemoglobin means it usually shows the average blood glucose level for past 3 months. So here what happens in type 1 or in any of the kind of diabetes, what happens, sugar is there in the glucose is there in the bloodstream only, right? So people who are suffering from type 1 diabetes, the sugar will be present, the glucose will be present in the bloodstream because it is not taken up by the tissues or any of the organs. So the glucose will remain in the bloodstream. Now in the bloodstream, blood also contains hemoglobin. So what will happen? This glucose will be binding to our hemoglobin. Okay, and so that is the reason the name is given, glycosylated hemoglobin. Fine. So it depends like how much percentage of hemoglobin is attached with glucose. Fine. So that if the higher percentage is there, then it means there is severe diabetic condition. Because if maximum hemoglobin molecules are showing the presence of glucose attached to them, it means that the high level of glucose is there in the blood. So HbA1c is the level, or A1c also we call it. If HbA1c is of 6.5% or higher during 2 separate tests, it means that the person is confirmed that the person is suffering from type 1 diabetes. Okay? Next is random blood sugar level. If the level is more than 200 milligram per deciliter or higher. Fasting, if it is higher than 126 milligram per deciliter. So in these cases, it is confirmed that the person is suffering from diabetic condition. Here again, it may be type 1, it may be gestation, it may be type 2, okay, or MODY. But it is not a confirmatory test for type 1 still. This is for generally for diabetes. Okay. Next is oral glucose tolerance test. So in this OGTT, oral glucose tolerance test, what happens? The person is called empty stomach, overnight fasting. Okay, at least 8 hours of fasting should be there. And in the morning, the person is on empty stomach. The person is asked to drink glucose. Okay, so glucose water. So after drinking the glucose water, then again the measurement of glucose is done. So so like 8 hours of fasting, then the person is asked to drink the glucose water. After drinking the glucose water, sugar level is measured after 30 minutes, after 60 minutes, and after 120 minutes. So after 2 hours, that is after 120 minutes, if still the glucose level is showing 200 mg per dl or higher, then it means that the person is not able to generate insulin. Okay, because in 2 hours, what happens? If we are drinking, if a normal person is drinking empty stomach, if the normal person is drinking glucose water, our body will immediately start producing insulin. So after 2 hours, the sugar level will come down. But in the people who are suffering from diabetes, type 1 diabetes specifically, their insulin production will not be happening. So the sugar level will be high in their blood even after 2 hours. So all these 4 tests, first 4, HbA1c, random blood sugar level, FBS, and OGTT. All these are the tests which are done for all the kinds of diabetes, okay, mellitus. But these 2 tests, C-peptide test and autoantibodies, these are the 2 tests which are specifically for differentiating type 1 from other type of diabetes. So C-peptide, before coming to the level of C-peptide, whenever insulin is produced in the body, so it is going through different stages. Okay, so first pre-pro insulin is produced. So insulin is basically a protein. It is a peptide. Okay, and it is having the structure which has all the amino acids in the structure. You would have seen the chemical structure of insulin. So there you can see that it is made up of all the amino acid sequences. So in this case, what happens initially, there is a production of pre-pro insulin. Then that gets converted into pro-insulin. And from pro-insulin, insulin is formed. So when pro-insulin gets into the next step, from pro-insulin, insulin is formed, and along with that, C-peptide is formed. Okay. So if we are able to diagnose the amount of C-peptide, if the C-peptide is low, it means insulin bhi nahi hua hai produced. If C-peptide is low, it reflects low production of insulin. Okay. So here, in case of type 1 diabetes, there is little or no presence of C-peptide. Normal range is 0.5 to 2 nanogram per ml. But if it is less than this, if it is less than 0.5 nanogram per ml, then it means that C-peptide is not getting produced. If C-peptide is not getting produced, it directly means that insulin is also not getting produced. Okay. And another test specifically for type 1 is autoantibody testing. These are all the different kinds of autoantibodies. Islet cell cytoplasmic autoantibodies. Okay. Insulin autoantibodies, IAA, they are also very common. Most common is GAD and GAD autoantibody, that is called GADA. Okay, glutamic acid decarboxylase autoantibodies. Then next is IA2A, that is insuloma associated 2 antibodies, and zinc transporter 8 autoantibodies. So these basically, this islet, insulin, GAD, insuloma, and zinc transporter 8, ZNT8. These are the proteins, these are the peptides against which the immune system is generating antibodies. Okay, so these antibodies are present only in type 1 diabetic patients, not in type 2. Because these antibodies will produce only if there is involvement of immune system. And immune system is involved only in type 1 and not in type 2. So this is a clear-cut test, clear-cut differentiating test between type 1 and other types of diabetes. Okay. Then coming to the stages. So just a minute. So coming to the stages of type 1, there are 3 stages. Stage 1, there is presence of 2 or more autoantibodies, but there is normoglycemia. Means it is a very initial stage. Again, this stage 1 will be detected only if we are screening the children for the presence of T1D. Okay. So because there is no change, the sugar level, the glucose level in the blood is completely normal. But if we do their blood test otherwise, if we test them for autoantibodies, 2 or more of the autoantibodies will be present. But again, we cannot understand at this stage because through just observation, because there are no symptoms and the glucose level are also very normal. Okay. So this is the beginning stage. Then next is, now in the first stage, autoantibodies are produced. So slowly what they will do, slowly they will start damaging the pancreatic cells. Okay. But then again, there are no other symptoms seen. Only dysglycemia is seen. Matlab, little higher, the glucose level will move towards a little higher side. Okay. And the third stage, there is onset of symptomatic disease. In the third stage, that is the stage when most of the children are brought to the hospital in the third stage. Okay, that is when the child will start showing the symptoms. जैसे कि ketoacidosis हो जाएगा. Ketoacidosis symptoms are the child having ketoacidosis will experience fainting. Okay, they will go unconscious, and that is when the parents, most of the cases, that is when the parents will or the guardian will carry the child to the hospital. And because that is a serious symptom, right? Otherwise, we are not checking the sugar level every day for any of us. So in the third stage, there is a clinical onset of symptomatic disease. Right? In the first two stages, first stage, even if we check the glycemia, even if we check the sugar level, we are not able to see any change. But if we do the test for autoantibodies, that time we will be able to see. So I just spoke before some time about screening the babies, right? So if there is any program which can, I don't think there is such any program in India or even in other countries. But if we come up with certain, the people who are type 1 diabetic advocates or any diabetic advocates, the people who are working for the cause of diabetes, maybe those people can think about it. If we get the government to, approach the government to get some guidelines, especially in India, let us first start with our country, right? So if we are able to screen when the child is taken for vaccination, the child have, like, as soon as the child is born, a lot of vaccinations are given, right? So during their first this thing, we can just decide some kind of timelines, that when the child is taken for vaccination, at that time, if we can do the blood test, okay, which for screening the autoantibodies, and that will be a fantastic thing, because if we are able to screen the people at stage 1, all the stage 2 and stage 3 can be managed. Okay, now coming to the management part. Yeah, so here it is, like, we have learned about the symptoms, risk factors, pathophysiology, what is the difference between 1 and 2, and how the symptoms are getting, how the symptom onset is happening, right? Diagnosis, everything. So the stages as well, seriousness of the disease. Now the last is management part. So before going to the case study, we will just discuss some of the management goals and the steps of management. So initially, first, the goal of managing type 1 diabetes is to prevent ketoacidosis. Because if ketoacidosis is happening, if the repeated episodes of ketoacidosis, DKA we call it, DKA, that is diabetic ketoacidosis, is happening, then in that case, the body gets deteriorated, starts getting deteriorated. So these ketone bodies which are present, which are formed in the body, they will start getting deposited in various tissues of the body. And they will destroy other organs also. Okay, because if the ketone bodies are deposited in liver, in kidney, any other tissues, all those other tissues are getting depleted. So we need to prevent ketoacidosis. Another thing is we need to prevent severe hypoglycemia. Again, hypoglycemia is more dangerous than hyperglycemia. Okay. So in case of hypoglycemia, the person can go into coma as well, and the person can also experience mortality. Means the person can be dead also because of hypoglycemic episodes. So we need to prevent DKA and we need to prevent hypoglycemia. These are the two major goals of management of the people who are suffering from type 1 diabetes or any kind of diabetes. Okay. Then because this type 1 happens in the children, so normal growth and development of the child is very important. Basically, type 1 diabetes, if it is managed, if we are able to manage the type 1 condition in the child using insulin, there is no adverse event happening on the growth pattern, the overall growth of the body. Okay, even the physiological growth, there is no issue happening in that. But then again, we need to take care that the normal growth and development of the child is happening as compared to other children. There is no difference shown in the growth pattern if glucose level is managed. Okay, but we need to take care of that part. Then we have to prevent the long-term diabetic complications. Now here again, this is a very important point, because in type 2, if the onset is happening at the age of 40 years, okay, of the disease, type 2 diabetes, then in that case, the complication will start happening after at least 10 to 15 years. So if the person is 40 years per diagnosis is done for type 2, the person, average I'm saying, not in case of everybody. Some people are very ignorant, for them complications happen from the day 1 itself. So, but we are just talking about the normal average condition. So in case a child, if a person is detected type 2 at the age of 40, around the age of 55, they will start developing the complications, microvascular, macrovascular complications. Okay. But in type 1 diabetes, the child, usual average age of child when the type 1 is detected is around 7 to 10 years of age, 5 to 10 years of age. So just imagine, even a child of 10 years, if the detection is there at the age of 10, and we are not taking care of the complication part, around the age of 20, 22 years, the child will have various complications. Okay. So then that person has to live the whole life with those complications, right? So we need to take care about the complication part more seriously as compared to type 2. So type 1 may, the complication, avoiding the complications is very, very important. Okay. Then when we are talking about complications, sugar level, the management part, basically the management part of type 1 or type 2, any kind of diabetes, the management is also associated with impotency. Okay. So even the decrease in the libido is seen in the people who are taking metformin, metformin as in oral hypoglycemic agents and insulin. So here again, we need to avoid the complications, because if the person is getting detected at the age of 10 years, by the age the person gets adult, the impotency issues may start happening. So again, complications needs to be taken care of, to be addressed very well. Even microvascular, everything needs to be taken care of. The next is prevent or delay the appearance of late disease complications, same as like above, and decrease mortality and maintain good quality of life. These are the normal things. Then these are the guidelines. So guidelines means what all things we can use. So when it comes to type 1 diabetes, we all know that type 1 can be managed by using insulin. Different kinds of insulin are there. We'll see what other kinds of insulins are there. So first is insulin. And in some of the cases, after the onset of the clinical disease, in some of the cases, metformin is also given along with insulin, because insulin is given to the patient because insulin production is not there. Okay. But in some cases, type 1 patient will also have insufficient insulin, and they will also experience that the body is having insulin resistance. So even if we are giving the insulin, external insulin to the patient, still that insulin is not able to work because the person also has insulin resistance. So in that case, we need to give metformin, because metformin will decrease the insulin resistance, right? Not in all the cases, but some cases, metformin is also needed along with insulin. Other disorders which are happening, diseases, lifestyle diseases happens with type 1 diabetes, or in diabetes in general, that is hypertension happens, right? Then hypercholesterolemia happens. So we also, after a few years down the time, the person may also need the blood pressure measure maintenance drugs, or cholesterol medications. Such drugs may be needed. Okay. Now these are about the medical treatment. Now the next is non-medical treatment, or we can say non-pharmacological treatment, or lifestyle modifications which we need to monitor. So daily, for type 1, there is no option. Daily sugar monitoring is required. Okay. Type 2, every 3 months they need to check. But for type 1, every day blood sugar level monitoring is required, because the insulin dose depends upon the blood sugar level. Then in type 1, carbohydrate count is very important. So the children are not allowed to, that's the sad part, but children are not allowed to eat whatever they want. So there, the strict monitoring of carbohydrate intake is measured here. So they have to cut down on wheat, on rice, and a lot of other things they have to give up. Then next is foot care is very important. Okay, every day they are the people who are having type 1 or type 2, they are told that you always need to wear shoes. They have to cover their foot all the time. Exercise and diet is required. Diet means, I'm not saying that eat less and all. Here the diet means carbohydrate count, protein intake, everything. Then regular medical checkups are needed, because diabetes is one condition which will give rise to other issues. So throughout the life, body checkup is very regular, at regular intervals. It is very important. And in case of people who are planning a family. So preconception counseling and contraception is also very important, because there is a interaction between the contraceptive pills and certain oral hypoglycemic agents. So if insulin is taken along with metformin or any other oral hypoglycemic agent, they may have contraindications with the contraceptive pills. So in that case, other methods of contraceptions are advised. And in general also, to type 1 diabetic people, not many drugs are recommended, because lot of drugs have lot of side effects. We all know that drugs always comes with side effects, right? So already the patient's body is compromised. In type 1, immune system is compromised because of the type 1 diabetic condition. Because of the high glucose level, already the patient's other organs in the patients are already not very normal, right? So in those cases, we need to avoid maximum drugs. So in that case, again, other methods, physical methods of contraceptions are advised as compared to hormonal treatment or any medication. And even preconception counseling is very much important, because the girls especially, the girls who are type 1 diabetic, if they are planning pregnancy, lot of complications are bound to happen. It doesn't mean that they cannot get pregnant. They do get pregnant, they also deliver healthy child, but then lot of counseling is needed. So it is not like that it is a problem. They can bear a child, they can give birth to a normal healthy child, a healthy baby, but lot of guidelines needs to be followed. So they have to take care of certain things, which the diabetologist and the gynecologist are supposed to sit together and advise or counsel that lady who is type 1 diabetic and who is planning pregnancy. So now coming to the insulin part. So here I've just said, right, that insulin is the major management option. We can't say treatment, it is just a management option. So various types of insulin are present in the market. Some of them are listed here. This particular diagram, I think most of the pharma and medical students will be knowing, because this is taken from KD Tripathi. This is my favorite diagram. I use it everywhere. So different types are rapid insulin. Rapid acting insulin means immediately there will be onset of action. Short acting insulin, they will be acting for a shorter duration. Okay. Examples are already listed here. You can just go through the names. Rapid acting insulin includes Lispro, Aspart, etc. Then regular insulin is a short acting insulin. Here the onset and peak and duration is also given. Immediate acting, again, they will be acting immediately, but the duration is for 20 to 24 hours. That is how it differs from rapid acting. And long acting insulin, they are showing its activity for up to 24 hours, or sometimes more than that as well. These are all the same things. Like first line, in case of management, the first line is a combination of first line treatment or management option is combination of basal and bolus insulin, that is immediate action and long acting. Uska combination usually is given. So these are the various options for the basal, glargine or NPH or detamid or degludec. And in case of bolus, we can see whether we can give Lispro or Aspart or glulisine, fine, or regular insulin. So usually it is a permutation combination the doctors do, because different people, different body is reacting in a different way. So we need to start experimenting the combinations. We call it as individualized medication, right? That's a very common term nowadays people are using. So individualized medication. So in this, insulin is the best example of individualized medication, because every body will react in a different way. So every child will react in a different way, and the same child at different age, the body will react in a different way. So again, the basal bolus combination needs to be checked by combinations. They can just try some of the combinations, observe the blood glucose, and then give a sequence or give a fixed combination to them later. Second line, these are the second line options. Again, NPH is there, Aspart is there, Lispro, Degludec is there. Right? These are the fixed dose insulins. Okay. Usually fixed dose insulins are easy to administer, but I mean, for the patient, from the patient perspective also, they don't have to, what do you say? They don't have to like worry about the glucose level. But as far as my experience, I think fixed dose combinations are not as good as the personalized combination, because it is always better to check the glucose level and then inject the units as and when it is required. Now, these are the complications. I think this is, again, we have already discussed the complications of type 1 diabetes, so need not go in detail about it. Now, these are some international and national Indian guidelines which are followed for the management of type 1. You can just go through the websites and just see, like, what is the current scenario. Whatever we have covered, it is all included. Whatever is there in these references, it is all included in the presentation. But still, if you would like to go, ICMR is one of the things in India which is followed. Then Maternal Health Division, MHRD. Okay, so Ministry of Health and Family Welfare, Government of India. This is also one of the website which you can just go and visit. And especially for diabetes, you can visit the National Center of Disease Control and Directorate General of Health Services, Government of India, okay? As well as Indian Society for Pediatric and Adolescent Endocrinology. So that was about the basics of type 1 diabetes, starting from the risk factors, etiological factors, and their complications, management, pathophysiology, how they differ from type 2, right? Now, this is the current research scenario. Okay, I think we don't have so much of time, but because we also need to discuss one case, but still I can give you some overview about the current scenario, current research which is going on in type 1 diabetes. Stem cell therapy is one area which is being explored nowadays a lot, and even my team is also working on stem cell therapy. We have shown various good results in preclinical as well as in clinical studies, where we are using different types of stem cells, different sources of our team is working basically on mesenchymal stem cells, but even pluripotent stem cells have shown good results. So various stem cells are used nowadays to cure, not to cure, but to manage the immunology involved in type 1. According to our study, we used umbilical cord derived mesenchymal stem cells, and they are showing good results as an immunomodulator, because here in type 1, immune system is the base, right, is the problem. So we need to modulate the immune system. We need to get a good balance between Th1, Th2 responses. So stem cells have shown really good results in that. We are still extrapolating it into the clinical studies, but as far as current results we have got good results with stem cell therapy. So you can also explore those areas. Another area is immunotherapy. Currently, we have also worked on one meta-analysis we have done actually on the immunotherapeutic drugs. They are antibodies, antibody-based drugs are there. And I can't give you much detail because it is still under process. So once it is published, I'll share with Dr. Singh, and maybe then he can share with the other with the participants here. So immunotherapy is also one area, but here the immunological drugs are used. But the major issue associated with immunotherapy, as far as my experience is concerned, I feel that immunotherapeutic drugs have a lot of side effects, because basically they are reducing the exaggerated response. So in type 1 diabetes, it is an autoimmune disease where the immune responses are exaggerated. So these drugs are kind of immunosuppressants. So these drugs will reduce the immune reactions. So that will again lead to counteracting with the other infections and all those things. And there are a few studies which says that some of the immunotherapeutic drugs or immunosuppressant drugs, they are also triggering diabetic conditions. So, this is again an area which is a dicey kind of a thing, but still you can explore more if you want to. And the third is vaccine development, which we are working, we are actually too much into this vaccine development research right now. Again, there won't be much data which I'll be able to share, but we are just trying to modulate the immune system with using certain vaccine formulas, and we are also trying to get the immunotolerance by using the formulas. So once we are done with the study, we will be sharing the results with you. So that was about the type 1 diabetic condition, basics of type 1 diabetes. If we want to actually study the exact details about the pathophysiology, about the immunology involved in type 1, it can become actually another course altogether. So for now, I think you all must be clear with the basics of type 1, with how the immune system is getting disturbed and how it is getting disturbed.
Yeah, Dr. Shivani. And one more thing, if you want, we can. Yes, no. Can you hear me?
Yeah, I can. Yes.
So if it is fine with you, we can take this case some another week, maybe on Friday or some other day. If it is fine for you.
That would be great actually for me.
That's cool then.
Yeah.
That's cool then. The case can be taken some other day because it is already.
Yes.
Is it fine for you?
Yeah. Sure. Yes, definitely. So
okay,
maybe we can schedule it some other time. Yeah.
Yes, definitely. So guys, now this time for the questions, you can just type your questions and we will communicate with Dr. Shivani. And yes, the class was amazing actually. I was listening the entire class and it was really good. And even I got the remaining knowledge what I did not have.
I am actually sorry. Thank you, by the way, but I'm sorry. I think the time got extended also. But when it comes to teaching, now I just can't help the time part.
That's totally fine. I actually was expecting 2 hours of your class because you have that much potential to complete in 2 hours, and I was thinking even more. But that's fine. Okay, so we'll take the questions now, Dr. Shivani.
Yeah.
Okay, what trigger factors from hypothalamus for the secretion of insulin? I think you have completed this.
Yeah.
Okay, and then carbohydrate countings may be difficult for the aged patients. So how to counsel them for this, ma'am?
Aged patients?
Yes, for the aged patients.
Okay, so even for children, the same issue happens, because even though they have parents, but in many cases, this calculation is an issue. So the dietitians have a chart. Okay, I can show it maybe in the next class, that dietitians have some charts which shows that this roti, for example, a wheat roti, has so many carbohydrate counts. So here we need a dietitian. We cannot do it. I mean, only a dietitian can do the counting. So they have to go to the dietitian, consult them for the counting part of the carbohydrates.
Correct.
Even proteins, they need to count.
Right.
Yeah.
Okay. So next question here is, what is the impact of progesterone or estrogen on insulin secretion?
Okay, so progesterone and estrogen, basically they don't have any interaction with the insulin secretion part. But here in type 1, secretion is not happening. So here that question doesn't come. But yeah, apart from this type 1 and type 2, if we take, there is no interaction between, I mean, there is no specific decrease or increase in the insulin pattern based on the progesterone estrogen, as far as I know. But again, I'm not a master of type 2, so I can't comment exactly on this. Yeah.
Right. No, that's fine. Actually, there is not much difference exactly.
Yeah, right.
Okay. Ma'am, how the trace elements affect the patient with diabetes mellitus?
Trace elements, and I mean, I didn't get the question.
Okay, I have, this question I can answer very clearly, but I have to read the thesis, because that was the study. And if I am not wrong, one of my friend has done the research on trace elements and, diabetes mellitus and their impact on GlyHP. So it was like, after 4 years of the diabetes, they have, distributed their patients in, 2 scenarios, like less than 4 years from the onset and more than 4 years of the, from the onset. So they got that selenium and, some calcium, or there are multiple, trace elements which were decreasing, over the time of, the diabetes period. And copper was increasing with the, time of, with the duration of diabetes mellitus. So it shows that, there were the deficiency of selenium, and even they have concluded like these trace elements could be one of the biomarkers for diabetes complications, and for the early complications or late complications by their levels. So this is very much significant. I'm not sure because I have to open that thesis, and definitely, but I'll come up with the numbers and I'll come up with the exact results. What was the conclusion? But I remember that very clearly, and this was the live result that Manipal itself, someone has done, my friend has done on trace elements and the diabetes and GlyHP.
Oh, that's a very interesting information. So
yes,
thanks for sharing.
Yes, and I'll be sharing in the next class the complete thing, definitely.
Yeah.
Okay.
And I would like to attend that because it would be something really interesting.
That would be mostly that would be mostly your case only, Dr.
Okay.
Okay. Okay. So how immunotherapy area will be better for type 1 diabetes? I think that we have discussed already, right?
Yeah, immunotherapy is usually they use suppressants, but again to decrease the exaggerated immunological responses, but they have certain limitations.
Yes.
Which we discussed. Yeah.
Okay. So do insulin preparations like Aspart and NPH come under biosimilars?
Yeah, they come under biosimilars. Basically insulin is a biosimilar.
Yes, exactly. Okay. And then reason for occurrence of type 1 diabetes in more than 25 to 30 years of the age. What is that?
So in some, like there are very rare cases in which about 25 to 30, the people start developing the clinical onset of the disease. But this happens because during their initial ages, the genetic codes are in the dormant state. And if there is any trigger, like even viral load or any of the other trigger is there, which is changing the genetic code. So genetic codes were already deformed, but they were in the dormant state. They were not dominating. So if there is a trigger, then especially viral load, then in that case, the dormant state will become activated. And it can happen after 30 years also.
Yes, so I'll add to Dr. Shivani here. We are doing the ICMR, young diabetes registry. Yeah. So, the research says that, if your parents are diabetic, if the person is coming in the ages in the middle age, like from 25 to, 35 or 40, it is, mainly because of their parents have the diabetes history. And it happens, it occurs in the generations, in the next generation, it occurs 10 years before of the onset of parents. It is like, if the parents have, their onset of diabetes and the parents was 40 years, then it is expected to be, the diabetes in the, children at the age of 30. So this is the major, factor we are seeing, around in the, around the globe, actually, not in India only. So there are the studies like, now, because now it is a revolution in the diabetes, and everywhere, diabetes cases are increasing exponentially. So everyone is looking into different aspects. And previously the diabetes was in elderlies, and, that epidemiological data says that it was very less in kids, but now it is very, very high, prevalent in the kids also, and in the middle-aged people it is coming, like diabetes, type 1 diabetes. So there are multiple factors which are coming out, but yes, genetic factors and the family history is one of the major factor what we have seen, or what I have read.
There is actually one more thing which has come up, 1.5. So type 1.5 is kind of coming in between 1 and 2. Some symptoms are from 1 and some are from 2. They are immunological diseases but showing symptoms of type 2.
It is very confusing. It is very confusing, and it is like a gray, diabetes.
Gray
same
area.
thing. Yes, gray area, and same thing happened with heart failure. I remember when I was doing in 2016, they have come up with a new, range of new range of heart failure that is called mid-range ejection fraction. One was like preserved ejection fraction. One was reduced ejection fraction, less than 50, more than 50. But in 2016, they have come up with the mid-range ejection fraction, which is 40 to 50. Like, and they are saying this is happening only, heart attack is the major, major, cause for the mid-range ejection fraction that can be recovered in 1 year or 2 years, maybe with the medicines. So they came up with the new gray area, and now that is, dominating other two, heart failures. So that's how the new confusing things and new revolutions and new, sciences coming up with the, new questions actually.
And that is making research more interesting.
Interesting.
Yeah.
Okay, so how
Yes.
can we manage if it is early detected? Okay, it's like insulins and yeah, please go ahead, Dr. Shivani. So you.
So in the early detections, because of the stem cell therapies, and even I wouldn't want to disclose the formula, but there are certain researches which are going on. Even clinical trials you can find on clinicaltrials.gov. Website.
Yes.
There are some products which we can, or formulas basically, not products, so formulas which we can use to modulate the immune system and to get the immune system acquainted with the new onset, I mean recent
Yes.
onset. So if the stage 1 or stage 2 also, if it is detected, then this may help. And in the initial stages, if we give stem cell therapy, we are able to see the reversal of type 1 diabetes. So that can be done. Of course, more trials needs to be done for this. Phase 3, phase 4
Yes.
trials needs to be done for this. But phase
Yes.
1 has shown good results to us.
Yes. So, okay. Puarshan is asking, is there any drug available to proliferative beta cells in type 1 diabetes?
Actually, there are some herbal drugs which claim that herbal companies, nutraceuticals basically, the companies
Yes.
are claiming that they are able to generate beta cells, but I don't believe, because yeah, because it is a biological process.
You,
Yeah,
you,
there is no
you, you,
disrespect.
you
Sorry.
won't believe, guys. Today I came across, one this medical representative. He came to, he just entered to my cabin, and he was, like, sir, this is a gift for you. I told, what is this? Seriously, today around 4 o'clock when I was just coming home, so he was like, sir, this is LED light, and it is like a vitamin D deficient. It is for vitamin D deficient peoples. I mean, how it works, so when you are sleeping, keep it in your room and your vitamin D deficiency will go away. Your vitamin D, your vitamin D will increase, your vitamin D levels will increase. And light, how this light will work in the vitamin D, sir, I don't know much, but this is the formula that they are saying, like, no need to take tablets or no need to go to sunlight. This light, this LED light, which is very low, maybe what was the formula, I also don't know, but they came up with the with that light, it costing around 4,000, sir, but it is like, it will give you the vitamin D, it will increase your vitamin D levels in your body while you're sleeping. I was really wondered, like, how
They
they're
have the
marketing,
most, then we are exposed to the risk of mutations in this cases then.
how their marketing skills are, and how they're selling the things on the basis of your disease problems or your disease condition. It is really creating trouble to everyone.
Whereas the stem cell therapy, actually, to add up to the question which was asked, there is no product which I believe it is reversing, it is generating pancreatic cells. But stem cells, why they are able to generate is because the mechanism we have studied, the stem cells are the biological cells basically. So we are just manipulating our own cells. So in that case, in that case, the regeneration is very much possible, because that is a biological cascade. But any product, if they say they are going to regenerate, don't believe.
Yes.
At least for now.
Monica is asking, what is the life expectancy for type 1 diabetes patient? There is nothing like they're reducing the life expectancy. If they are in good control, they can survive like a normal person.
Yeah, yes.
So, okay, one more question we will take.
Sure.
What is the effect of pancreatic cancers in people with diabetes?
Effect of pancreatic cancer. They will exaggerate the whole response, because already pancreatic cells are becoming tumor cells, and already the cells are damaged, getting damaged because of diabetes also. So they can cause severe pancreatitis, and pancreectomy is needed in such patients. Maximum cases, we are having diabetes as well as pancreatic cancer. So it is very serious issue. Their insulin needs to be given.
Yes, one question is there, but I will frame it in my way. Praveen Kumar is asking, ma'am, if any type 1 diabetes patient, especially child, get normal glucose levels in adulthood, is it naturally or accidentally? So I think this question should be like, is there any chance of type 1 diabetes kids to get normal in the adulthood?
We have not come across any such thing, but again, I cannot say no, because you never know. Nature is above science. So I have not come across any such case when the reversal was done by itself.
Yes.
But again, if the genes changes in those cases, the way it gets mutated,
Yes.
there is a possibility that the mutated genes can also get reversed.
Reverse.
Further mutations can happen, and those
Yes.
further mutations can become normal.
Yeah, and further mutations can happen due to maybe yes, some other treatments, therapies, procedures. That could be anything, you know.
Anything,
some toxic elements also. Sometimes I have seen that I have seen that people who are coming with the poison, poisonous cases, they have attempted suicide, and they are, their genetic problems are totally gone now.
Yeah, that's what.
I have seen such 1 or 2 cases, because it happens. It happens. You don't know what kind of, element can trigger that genetic.
It can be accidental, but
yeah,
the way A gets converted to B, but then B can also get converted to A. So we never know. Yeah.
Okay, guys. So thank you, and thank you, Dr. Shivani. Thank you for the wonderful session. It was really nice, and hope to see you very soon on the Friday maybe. And get ready for the case also. She will be analyzing the case, very beautiful case of type 1 diabetes. So thank you very much, and thank you very much for answering all the questions. Thank you, guys.
Thank you, Dr. Desai.
Yes, thank you.